Okay, so this is going to go over chapter 16, and we're going to start off by talking about abortion. And of course, when we think about abortion, we're thinking about voluntary abortion, but here we are talking about involuntary abortion or miscarriage in layman terms. Abortion can be caused by numerous different factors. It can be, usually it's chromosomal, but it can be infection, it could be drugs, it could be cervical insufficiency, it could be hormones. There's a lot of different things that could affect or put you at risk for abortion, again, or miscarriage, however you want to do that. People at higher risk for just about anything are going to be teenagers and people over 35, which again puts you at risk for just about everything. Um, there is several different types of abortion. There's threatened, imminent, and I'm abbreviating, complete, incomplete, reoccurring, and septic. Alright, so these are all different types of abortion. The threatened is going to be that the fetus is still alive, but there's a bleeding risk. And when we have a bleeding risk, the way I thought about the ABCs now is ABCs apply to the fetus. And again, we're not going to have airway and breathing as part of a fetal assessment because obviously they're not breathing at that point in the sense that me and you are breathing. But bleeding is going to be a significant risk factor for them and of how they're getting the nutrients and blood flow that they need. So bleeding is going to be a high priority. Of course, when we have bleeding, you want to limit exams as much as possible, but you still need to figure out the cause. So fetal monitoring, blood pressure, heart rate. It might be that you had some type of placental abruption, and that's of course going to be an issue. Bed rest, elevating that right hip, increasing the blood flow to the fetus. So that's a threat. And imminent is cervical. You've had cervical change, or the os has been dilated, and there's at that point not really anything you can do about it. Complete is where everything comes out as it should. In a miscarriage, everything comes out placenta, and there's no remaining parts. And incomplete is where you're going to end up having a D&C. If you're in that first trimester, and the second trimester, you're looking at evacuating whatever's left through dilation and evacuation, or D&E. So D&C is a little bit less, well, I would say less invasive, but you don't have the evacuation the same thing because obviously we're talking about a larger fetus here. Reoccurrent, that's more than 3 times, and you would be labeled as a reoccurrent maternal reoccurrent abortions. Septic, of course, is infection of some sort, whether it be the fetus, the amniotic fluid, or the mother, and those are the different types. Symptoms of this. Symptoms of this are going to be cramping, bloating, back pain, which are signs of labor. Bleeding, obviously, is going to be an issue. It should be, in theory, darker blood, but it could be bright red and bright red. Continuous bright red, of course, we need to be looking at hemorrhaging and oxytocin at that point. IV fluid replacement. All right, so your treatment, and again, the treatment. First of all, your symptoms are going to be exactly what it looks like when you go into labor. Your treatment is going to be BP, look for shock, hypovolemic shock due to blood loss. If you have 12 weeks or more, you're going to get a Doppler heart rate or lack thereof. IV, you need a complete CBC with hemoglobin and hematocrit. And again, hematocrit should be 3 times that of your hemoglobin. So if my hemoglobin is 11, then in theory my hematocrit should be 33. But it's just a little trick that they went over. Anytime you have that bleeding risk, you need to be starting ROGAM. Usually, of course, we would get that after labor, postpartum. If the mother is a RH negative, then they need ROGAM, so that way they don't have hemolysis and coagulation as a result of a secondary pregnancy. And that, again, has it to do with the antibody on top of your blood cells. So that's what makes it type. So if the mother is negative, then they need ROGAM. And if there's bleeding and we're not sure of the fetus, they still need ROGAM, just so that way we can make sure that they're covered. There is something called the Combs test, which can test to see if you already have that titer, and then of course you would need it at that point if you've already been given it at some point. Okay. Ectopic pregnancy, which would kind of fall under abortion, but not in the same sense. Ectopic pregnancy is, of course, going to be not in the uterus. It's going to be in the fallopian tube, and this can be severe for the mother. Obviously, we're not going to be able to save a fetus that's been implanted into a tube, but you do need to worry about tubal rupture and then abdominal bleeding. So, of course, but now we need to look at hypovolemic shock. Large catheter needle for replacement of CBCs, cross-match blood. It's the symptoms for this are going to be a sharp pain, abdominal rigidity, just because if your tube ruptures, then you're going to be bleeding through abdominal cavity. And your treatment for this, methotrexate, methotrexate. Okay, methotrexate. Methotrexate is going to disrupt the ability for folic acid. It won't allow for cell proliferation, i.e., this causes abortion of an unwanted pregnancy, or in this case, an ectopic pregnancy, which if it wasn't aborted, then the mother would possibly die. So, worst case, or not worst case, but you might want to look at a laparoscopic surgery. This would prevent damage to the tubes and hopefully enable the mother to be able to conceive again. So you do need to wait a couple months after an ectopic pregnancy or an abortion, so that way your body's been repaired. All right. All right, gestational tropioblast disease. So GTD, gestational tropioblast disease, is going to, there's several different types, but it ends up that you have some type of mole that is not compatible with life. You could have a mole that they're called molar pregnancies in layman terms. So your hydrophilic mole. Long story short, this is going to create fluid-filled, and it's almost like a placenta, so it's placenta-like, but fluid-filled sac. The symptoms of this, of course, would be passing of these sacs. All right, and then you also have complete. A complete is it's developed but has no DNA inside. Partial is going to have 69 chromosomes, which of course is way off, and usually means that 2 sperms implanted and gave you those extra chromosomes. And then you have a invasive mole, which is similar to your complete mole, except for the fact that it disrupts the wall or the myometrium of the uterus. So basically, all these are just they're not compatible. They're not living. There's something wrong where it's created some type of mole, and it can be cancerous, but usually it's a proliferation of cells. It's very erratic, and the outside cells just continue to proliferate. Your symptoms for these, again, bleeding, and again, usually you start blood, grape-like clusters from your hydrophilic mole, and high HCG, which of course we use to test for pregnancy, twins, Down syndrome. And with high HCG, you're going to have hyperemesis gravidarum, which essentially means that you're going to be extremely nauseous and vomiting to the point of electrolyte deficiency, hypovolemia, things of that nature. So when you have high HCG, you're going to have this inevitably because it creates that nausea vomiting. And they're going to need fluid replacements for that, electrolyte balancing. So Again, same thing. Anytime we're talking about blood, we want to go back to a ROGAM. We need to make sure that future fetuses are successful. Evacuation, and again, you want to possibly check for cancer on this. All right, hypertension. Let's move on. Hypertension can be chronic, it can be pre-existing, it can be gestational, and it is generally related to complications, other complications. So hypertension, of course, is you're going to have more blood circulating, so you're going to have more pressure. And that's one thing. But when you get into that 140s over 90s, you're talking hypertension. Hypertension can be, again, pre-existing or gestational. One type of hypertension is preeclampsia. Preeclampsia. All right, preeclampsia. Preeclampsia is hypertensive disorder. It's usually 20 weeks of gestation or more when this comes about. It can be mild or severe. And of course, eclampsia is very bad. But eclampsia, mothers that are have eclampsia are at higher risk for that GTD, the gestational the mole pregnancy, essentially, the GTD. Sorry. All right, preeclampsia. Your signs and symptoms of preeclampsia are going to be elevated blood pressure, anemia high. 20 weeks plus. Your bun level should be very high, so your nitrates inside of your blood are going to be higher. Decreased unit, your GFR is going to be down, so decreased renal capabilities, which of course is why you end up with that high bun. Basically, this is all caused from narrowing of vessels or thinning out of the walls, and when you have that happening, you're going to end up with that interstitial or tertiary edema as fluid goes into other areas. Vessels also start to collapse or die off and become thinner, more closed off, and that's going to create more pressure, and that's where you get that hypertension from. The worst headache of your life, that's very important, and of course, if you have hypertension, you're going to end up with a headache because there's plenty of vessels going to your brain or to your head, and that's going to create that headache that they're talking about. So renal failure, you're also going to have liver. It's possible for the liver to rupture. The reason why the liver would rupture and you have increased liver enzyme is going to be because as blood vessels or blood cells try to go through narrow passages, they're going to be broken down, and you're going to end up with elevated liver enzymes. And probably bilirubin because your body's trying to break down all that fragmented blood. Again, blood cells injured through the passage of small vessels. Pulmonary embolism is another thing, and again, everything is affected because this is a systemic vascular issue. So the fetus is at risk for for gestational age, although of course this is related to diabetes as well, which creates a lot of vascular issues, and they would have large gestational age. But anyways, generally small for gestational age, and that's because the fetus is not getting enough nutrients that it needs to be able to grow. They will often be hypoxic and malnutrition. So that's your preeclampsia. Let's talk about severe preeclampsia, which is just slightly turned up a notch from here. And again, these are all hypertensive disorders. Severe preeclampsia, you're talking about a BP 160 over 10 or higher. Your proteinuria, I should have mentioned that before, but proteinuria protein in your urine is going to happen. You might be 1+, 2+, but when you get into the severe preeclampsia, you're talking a lot higher protein in your urine, 3 to 4+, and of course that's going to be caused because of renal, because of holes made inside your glomerular, essentially your renal system is not working the way it should, and protein that should not be passing out is going to. Again, that another cause of edema, leading to loss of end-product pressure. Oliguria, and of course, olig means few, urea means urine. That's going to be a decreased urine, less than 500 milliliters in 24 hours. And of course, we know that 30 milliliters per hour is our normal rate, what we're looking for. It's a little bit harder because if you're in renal failure, we're not going to give you more fluids in renal failure. Renal damage, yes, but so you're also going to have impaired liver, and that's going to be because they're trying to process all the blood cells. Low platelets. So you have low platelets, and the reason why is because when you have a vessel and the vessel is injured, all the platelets are going to go to that one specific area, which means that they are not going to go to other areas. So the osmolality as far as the viscosity in the blood as a whole is going to be very small because the platelets are trying to fix damaged cells. And now that I have this up here, when you have nearing of a passageway, red blood cells are going to try and get through, and as red blood cells try and get through, they might be broken up. So that's going to deposit fibrin, making these even smaller. All right, so as they deposit fibrin, obviously when you're trying to get fluid through this area, you're going to increase the pressure because the space has decreased it. So increased pressure directly and proportional to space. So low platelet counts. You're going to have nausea and vomiting, edema and seizures are always going to be a risk with hypertension. Procedure and cautions, seizure precautions, we're going to treat that with magnesium sulfate. I'm not sure if there's a plus there. Anyways, so we're going to treat that with magnesium sulfate, which of course could lead to toxicity. Anytime you do magnesium, you need to watch for toxicity, drooling, difficulty swallowing, and of course respiration rate is going to be lower with lack of deep tendon reflux. So decreased deep tendon reflux with magnesium sulfate toxicity. Eclampsia. So we went over the mild preeclampsia, severe preeclampsia, and the only difference between those and eclampsia is if the condition, of course, is even worse. You have grand mal seizures. Seizures can last far past that, past postpartum, and that's very life-threatening. The other symptoms, of course, is weight gain because of fluid retention. Bed rest, we need to do sodium restrictions, ultrasounds, PPP, biophysical profile, so that we can make sure that the fetus is getting enough nutrients. Doppler fetal movement analysis. Your antihypertensives. So your antihypertensives. Labatol, nifedipine. So this is going to be your oral one, and a lot of times they'll start with Labatol and bolus, and then go to this one. But those are antihypertensive medicines that are safe for pregnancy use. They are also going to look at any of your beta-methane zones for lung maturity. They want to make sure that the lungs are mature, because if you go into preterm labor, then the fetus has a better chance of not going into respiratory distress. So your beta-methane zones. The other thing about this is that as far as preterm labor goes, the only cure for preeclampsia or eclampsia is, in fact, delivering. So as soon as the mother is stabilized and the fetus is stabilized, they want to initiate labor as soon as possible. And actually, you can start oxytocin with magnesium sulfate, although, this stops labor right here and this starts labor. So but you can run the same things at the same time. I'm sure you need more oxytocin at that point. But the of course, long maturity is 36 weeks, viability 24. Okay, so let's move on. Disseminated intravascular coagulation is often related to preeclampsia and amniotic fluid embolism. Hematocrit is supposed to be 3 times level. So basically, this is coagulation, and that has a lot to do with closing off of the vessels, disseminated intravascular coagulation. So infections. Let's talk infections real quick. So infections. They have a little TORCH acronym. Okay, so and I just lost my track here. Toxoplasmosis is these are all perinatal infections, but toxoplasmosis, cat, raw meat, goat's milk, unpasteurized. These are all infections that you can gain while you're pregnant, and while they might not be that bad for the mother, they're very severe for the fetus. Your symptoms for this are going to be, well, for the fetus that is, cognitive defects, coma, convulsions, it's pretty significant, hydrocephalic, which of course hydro water, cephalic is brain, and that's water on the brain. Microcephalic, small head. Your treatment or your diagnosis, your diagnosis for this is for year to 1 titers. If you have anything over a 1 in 8 titer, it means that you already have the immunity. 1.8 and below, you're not immune. I'm sorry, I just went into rubella. So your diagnosis treatment for toxoplasmosis. Right, so your treatment here, or your diagnosis here, you're going to run the antibodies, and you're looking for ICG and ICGM, which that's a little bit more detailed than you need to be. The cytomegalovirus, it belongs to the herpes group, and mothers can be asymptomatic. Can lead to fetal tissue damage. That's just the diagnosis. We need to start running tests for that. Your herpes, of course, is going to be an issue as well. There are going to be lesions, primary infection associated with spontaneous abortion, low birth weight. Your treatment for herpes, let me get some of this off the page. So your treatment for herpes, and of course there's herpes simplex 1 and 2, associated with lesions, abortion, low birth weight. So your treatment for these are going to be aclovir, valacyclovir, and famotidine. So these are all your cyclovia. That's going to be your herpes. A lot of times those are passed to the infants. One of the reasons why we put that eye ointment on after. The rubella is the last one here. So rubella is, of course, rubella, German measles. And that's the one that you're going to run the titer on. 1 in 8 means you're immune. Below 1 in 8 means you're susceptible. And of course, we have vaccination for that. So it's virtually gone at this point. But you do need to run for that. So let's break down that TORCH acronym. Toxoplasmosis is your T, and these are all, again, all prenatal infections. Toxoplasmosis, cats, pasteurized goat milk, things of that nature. and that your toxo is where you get that TO from. R is for rubella, German measles, get your vaccine at 1 in 8 titer. C is going to be your cytomegalovirus, which is a form of herpes, and that would be a screen that you need to do. And then herpes, of course, we're going to treat with medication and try and prevent the spread to the fetus, which is hard. All right, so one thing that we didn't hit on was health. Why didn't I hit on that? The reason I didn't hit on that. So health. Health is got to do with your liver. Let's go real quick. So, and this is actually associated with preeclampsia. But I want to break it up because it's kind of different. So, hemolysis, elevated liver, liver enzymes. I'm not sure what we get that right out from there. Anyway, liver enzymes. So your ASTs, all that stuff. Low platelet count. Oh, I'm sorry. Low platelet. So elevated. So hemolysis, elevated liver enzymes, low platelet count. All right. So low platelet count. And this goes back to what I was talking about before. Again, very significant preeclampsia, but basically red blood cells are fragmented through the veins. You end up with liver dysfunction because of the pressure, the fragmented red blood cells that it's trying to process. Your symptoms for this are going to be epigastric pain, or i.e. your liver. Jaundice, of course, which is obviously a liver issue. Elevated liver enzymes to get your CBC. Thrombocytopenia, which is just low platelets, and that's because those are they are coagulating on whatever damaged blood vessels there is. So throughout the blood, you're not going to see a lot of platelets. Okay, so we've gone through preeclampsia, herpes, and abortion. In this, they also talk about blunt trauma, basic assessments, puncture trauma, and domestic violence issues, which I won't hit too much on. Strep B, or group B strep, so that's streptococcus again, so, or GBS, very common in women. It's just a bacteria found in the perineal area. Your symptoms are going to be illness, which is, hard to tell when you're pregnant because you're always going through those first trimester. Apnea, shock, of course, we know about shock, and pneumonia. You're going to run a screen at 35 to 37 weeks, and you're going to run antibiotics, which are probably going to be run anyhow. The antibiotics of penicillin, or one of your cillins, ampicillin, and if you've got allergy, that then clindamycin. So those are your pregnancy at risk, chapter 16.